Welcome to Advanced Practice Rheum. Hi, I'm Jack Cush with RheumNow. In this review, we're going to cover antinuclear antibodies and autoantibodies in general. Antinuclear antibodies, or ANA, are basically equated with the diagnosis of lupus, but they really don't equate, meaning that while everyone with lupus is going to be ANA positive, 99.9% of people, finding a positive ANA does not mean that you have lupus, and we'll talk about why. So the test is very sensitive, but poorly specific. The converse should also be considered. Could you have lupus and be ANA negative? That was very popular back in the 70s and 80s. It's really no longer possible now. It's virtually extinct. And so while you may be able to come up to me and tell me a case and point one out, it's like 0.1% of all the ANAs ever done. So trying to make a diagnosis in someone who's ANA negative, a diagnosis of lupus, you're barking up the wrong tree. So again, it is really a test that tells you you're maybe dealing with autoimmune diseases, and can be used as a confirmatory test. As I said, it's very, very sensitive, so much so that upwards of either 20 to 30 million Americans have a positive ANA in any titer, but only less than 300,000 are going to have lupus. That means about 1 in 100 ANAs will be due to lupus. Now, it can be due to other things, and we'll talk about that. How is an ANA done? It used to be done on a slide with cells, and they would take the patient's serum that has autoantibodies in it, maybe, and the antibodies would bind to nuclear antigens on the cells, and then they would put on a secondary fluorochrome that would bind to the antibodies, and they would read it under fluorescence. Now they do it by faster methods, including ELISA, which makes the test a lot more sensitive, meaning it's a lot more positive. Now, to define the cutoffs of what's positive, they take this assay and they apply it to your normal population where you live, and they make the cutoff at roughly 5, maybe 6%. When you apply that cutoff to normal, healthy people, it's 5 or 6% are going to have an ANA with basically zero risk of having lupus. However, you apply the same cutoffs to an elderly population, over 65, a hospitalized sick population. It's going to be a 3-fold higher rate of positivity. And that doesn't necessarily mean that they're going to have lupus. I mean, it just goes along with immunologic activation. So you need to know it's a very ineffective screen for lupus being talked about without criteria, or arthritis or arthralgia in general. You need a good reason to order the test. As we said, this may be found in other conditions. Most commonly, no condition at all. Second most common in my experience is autoimmune thyroid disease, Graves' disease, Hashimoto's, autoimmune thyroiditis in general. There are many other causes that are, so autoimmune disease in general, myositis, polymyositis, dermatomyositis, systemic sclerosis, antiphospholipid syndrome, autoimmune hemolytic anemia, and I could go on and on. Women who are pregnant have a doubling or tripling of the risk. It's 9 to 18% of pregnant women are going to be ANA positive but not have lupus. Same thing for chronic renal disease, especially chronic liver disease. Chronic liver disease is notorious for giving you not just ANAs, but lots of autoantibodies, including double-stranded DNA. It's associated with neoplasia. So the differential diagnosis is quite wide on any positive ANA. The significance of the test rests with a few things, especially, number one, the history. It's not significant if they don't have a history that doesn't suggest a diagnosis of lupus or another autoimmune disease, or liver disease, or lung disease, or et cetera. The significance also rises with titer. Titers of 1 to 40, 1 to 80, 1 to 160, I don't care about. They're truly nonspecific. Titers of greater than 1280, greater than 2460, greater than 10,200, whatever. Those you got to take a little more seriously. And then next, it's the pattern. What we do know about the use of the ANA is applied to the general population is poorly useful. It has really little predictive value. There's a study back in 1972 in Annals of Internal Medicine that showed if you had a few lupus criteria, the odds of getting lupus only went up until you had 3 or 4 criteria or more, right? However, if you add an ANA to that equation, same thing. You have to have at least 3 criteria to make an ANA provide added diagnostic value in making the diagnosis of lupus. So the indications, we said the causes. Age is a cause, threefold increased risk. Drugs are a cause, and there's drugs that just cause ANA positivity and drugs that also cause drug-induced lupus. They are the same. Drugs that cause ANA positivity are more frequent than drugs that cause drug-induced lupus. That's only a subset. It used to be that it was drugs like procainamide and hydralazine. More recent years, it's thorazine, lithium, quinidine, tetracycline, and TNF inhibitors are notorious for causing positive ANAs. The next most common reason is no reason at all. The ANA's out there, and you can just follow it and do nothing about it. The next most common reason is not having lupus, and again, no reason at all. And then finding an ANA or an ANA that gets referred to you has a small chance of having lupus, and then it goes up when these other things are in play. The history supports the diagnosis. The titer is very, very high. There's maybe that you do, because of the ANA, you do other autoantibodies. So what are the indications for ordering an ANA? There's only one, a clear suspicion of lupus based on criteria and clinical presentation. After that, you could order an ANA to evaluate the possibility of another autoimmune disease like scleroderma, like myositis, like Sjogren's. So in systemic sclerosis, 60, 70% are going to be ANA positive. In myositis, about 50% are ANA positive. In Sjogren's, it's up to 80%. In rheumatoid arthritis, 40% of rheumatoid arthritis patients have ANA positivity as well. The reasons to order it do not include arthralgia. Arthralgia is not a reason to order an ANA. You'll be having to spend a lot of time to explain why the ANA is positive in someone who just has arthralgia. Family history is not a reason, and the primary care doctor thinking that it should be ordered is definitely not a reason. As I said, it's nonspecific, and it is threefold higher positivity rates, just like rheumatoid factor, when you apply it to an elderly population over the age of 65. So the sensitivity of an ANA is, 98%. The specificity, however, is only about 57%. This compares poorly to other more specific autoantibodies for lupus, like double-stranded DNA, which is found in 50 to 60% of people, but the specificity is 97%. Also highly specific, anti-SM antibodies, 97% specific, but only about 30% of lupus patients will have that positive. That would be the sensitivity. RNP is not sensitive nor specific for lupus. Okay? So again, you need to think about sensitivity, specificity when ordering these tests. So just like the CCP antibody is a better, more specific test for rheumatoid when compared to the rheumatoid factor, double-stranded DNA and anti-SM antibodies is a much more specific test for lupus compared to the ANA alone. There's an article in Journal of Rheumatology in this year in 2025 that looked at multiplex ANA assays done on 2,500 individuals in one hospital system. The vast majority of these tests, these are ELISA tests done in bulk numbers, were ordered by primary care doctors and next by other medical subspecialties for hundreds of reasons. Of all the tests that were done, only 1.6% of the ANA negative group ended up having an autoimmune rheumatic disease, most often rheumatoid arthritis or spondyloarthritis. 1.6%, right? That's 1 or 2 out of 100. In the ANA positive group, out of, I got 2,500, 13.7% were positive. And I'm sorry, all of them were positive. This is 271. I'm sorry. So let's do this again. ANA positive group, 271 of the 2,500 patients. Of that group, less than 14% were diagnosed with a new rheumatic disease or autoimmune disease, most often Sjogren's syndrome, lupus, or undifferentiated connective tissue disease. Bottom line is that 97% of ANAs ordered by the general prescribing practitioners do not lead to an autoimmune or rheumatic diagnosis. So again, be selective in what you order. The important thing is to note not just the titer, but also the pattern. Most ANAs come back with speckled pattern, and that's horribly nonspecific. And the antigens that are being recognized are many. RNP, that's been associated with MCTD. SM, very specific for lupus. SSA or Rho, associated with Sjogren's. SSB or LA, associated with Sjogren's, but also other conditions. PM1, JO1, myositis kind of things. But speckled is very nonspecific, and you can order an extractable nuclear antigen test or individual titers of RNP, SM, SSA, SSB, SCL70, PM1, JO1, etc. Also nonspecific is a diffuse pattern of ANA staining. That's seen in almost nothing. It's due to deoxy-RNP and histones, antibodies to those particular substrates, and it's very nonspecific. It could be associated with drug-induced lupus. Most specific, as we said, is double-stranded DNA. And that used to give us a lot of what we call peripheral or rim patterns. We don't see much of that anymore. The things I want you to remember about patterns is that one, speckled is most common. Two, you often get reports of nucleolar patterns or centromeric patterns. Nucleolar patterns are associated, found in 40% of patients with systemic sclerosis, the diffuse kind. And that's due to antibodies against RNA polymerase 1 and a few other antigens. The centromeric pattern is seen in CREST syndrome. It's seen in 75% of patients with limited systemic sclerosis, and that's due to antibodies to the kinetochore. You can sometimes get cytoplasmic staining, and that can be sometimes confusing. So when you're using an ANA to diagnose lupus and you think of systemic lupus erythematosus, that's usually we're talking about the acute forms of lupus skin disease, the malar rash, the alopecia, bullous LE, and photosensitivity in oral ulcers. Such patients are always ANA positive. They may or may not have double-stranded DNA and SM. There are other forms of lupus. There's the chronic or discoid form of lupus, and you know what? Only 50% of them are going to be ANA positive and not have risk of organ disease like the acute LE rash and the ANA double-stranded DNA patients will. And in between is subacute cutaneous lupus. They often have antibodies against the ANA, but also you can prove that with SSA or Rho positivity. So there are rules for using ANAs. Number one, don't order an ANA unless lupus criteria are present. Number two, don't repeat the ANA over and over and over again. It doesn't matter if it goes from negative to 1 to 40 back to negative to 1 to 80. It's still nonspecific and kind of useless, right? And the ANA does not go up or down with disease activity. Don't order subserologies unless the ANA is positive. If the ANA is positive, go right ahead and check those boxes for double-stranded DNA, SM, RNP, SSA, SSB, ENA, basically testing extractable nuclear antigens, and maybe that'll give you further insight as to what's going on. As I said, there is no such thing as ANA negative lupus anymore, unless you're an expert rheumatologist dealing with thousands of patients. ANA sensitivity is variable in other autoimmune diseases, other connective tissue diseases, ranging from about 40% to 80% positivity. I would tell you, do not refer patients to rheumatology for a titer of 1 to 40 or 1 to 80 without other supportive features that would suggest an autoimmune disease. The antibody by itself is meaningless at those titers and is seldom pathogenic. Now, there are other autoantibodies, and the ANA is often very associated with the antiphospholipid syndrome, And here the triad is having an ANA, usually ANA positive, and they have one of the antiphospholipid antibody tests, either a biologic false positive RPR, test for syphilis, or anticardiolipin antibodies, or the lupus anticoagulant. And lupus anticoagulant can be tested in many different ways. What we see with the antiphospholipid syndrome is having, you don't have the syndrome if you have the antibody. Then you're just antiphospholipid positive with a very low risk of having any of the triad manifestations. However, if you have a positive antiphospholipid test, RPR, lupus anticoagulant, cardiolipin antibodies, you're now looking for the manifestations that go along with that. The main ones, the triad, is recurrent thrombotic events or major thrombotic events, spontaneous abortions and miscarriages, and refractory thrombocytopenia. There are other features that go along with this: migraine, Raynaud's, Liebman-Sachs, or sterile endocarditis, mitral regurgitation, transverse myelitis, and strange neuropathies. So these antibodies are found in lots of autoimmune diseases, lots of connective tissue patients, and they mean nothing unless they have thrombotic events, spontaneous abortions, and thrombocytopenia. It's found in 30% or more of lupus patients. If you want to know if the test is going to be pathogenic, well, look for those clinical features I just mentioned. Or order a beta-2 glycoprotein antibody, and that, along with an antiphospholipid antibody test, makes it much more likely to be pathogenic. If you find this, these patients need to be treated not with anti-inflammatory or immunosuppression. They need to be on chronic anticoagulation. Lastly, I'm going to talk about anti-neutrophil cytoplasmic antibodies, or ANCA. ANCA, as you know, is a test that was associated with Wegener's granulomatosis, which is now called granulomatosis with polyangiitis, GPA. It's found in 50 to 90% of GPA patients. When you find a C ANCA, or cytoplasmic staining of the neutrophil nucleus, neutrophil cytoplasm. So that's why I call it C ANCA. It stains the cytoplasm in a very sort of diffuse fashion. The antibody that is directly associated with a C ANCA finding is antibodies to proteinase 3. Again, that's the test that you would order if you're considering GPA. Sometimes the ANCA test comes back as a P ANCA in a certain titer. The higher the titer, the more you worry. The P ANCA means that the staining of the cytoplasm has a perinuclear distribution, and this is less specific. It's found in patients with microscopic polyangiitis, EGPA, the eosinophilic granulomatosis with polyangiitis, what was previously called Churg-Strauss syndrome, and sometimes patients with lupus and lupus nephritis. The antibody that goes best with P ANCA titers is the myeloperoxidase antibody. Now, there are a lot of other autoantibodies that I could cover. I'm not going to. I do want to make a point that I brought up in the last session on tests for inflammation. I want to give you the American College of Physicians recommendations about the use of the ESR. They sort of apply here. You got to be smart about how you use these tests and how you interpret them. In 1986, the Annals of Internal Medicine published these guidelines from the American College of Physicians. Number one, the SED rate should not be used to screen asymptomatic people. Number two, the SED rate should be used selectively and interpreted with caution. Extreme elevation of the SED rate seldom occurs in people who have no evidence of serious disease or inflammatory disease. Number three, if there's no immediate explanation for an increased sedimentation rate, you should repeat the test at a later interval, some months later, rather than undertake a long, expensive, and worrisome search for some occult illness. Number four, the SED rate is useful in the diagnosis and monitoring of patients with polymyalgia rheumatica and giant cell arteritis. Number five, in diagnosing and treating and monitoring patients with rheumatoid arthritis, the SED rate could be used to resolve conflicting clinical evidence. I don't know what to do. Is the manifestation inflammatory or non-inflammatory? SED rate or CRP could help you make up your mind. And lastly, the SED rate may be helpful in monitoring and treating patients with Hodgkin's disease. That's it. Tune in for more of these great videos.